Well, thank you, Fred. So we are pleased to welcome Fred Teran, who is one of our nephrology colleagues and chief of nephrology at the VA, who is going to talk about a topic also of great interest to me, but metabolic stones. So, Fred, thank you for taking the time and being here, and looking forward to working with you more personally as I, grow my work here. But thanks for being here, and we're looking forward to your talk.
Hope everybody's doing well. So I'm basically going to talk a little bit about just the basic workup of what AUA actually recommends, with a little bit of the latest information of possible genetic components involved. So no conflicts. So objectives for today are going to be discuss the risk for stone formation recurrence, discussing the general stone workup and sort of a holistic approach, and also discuss the possible genetic implications of stone development that have been coming up. So as you all know, the incidence is actually on the rise versus looking at the data from NHANES from several years ago. The incidence rate for men is up to about 20% and women about half of that. Those that are increased risk for stone development are males over 40, Caucasian, living in the South, okay? And anybody that has a higher BMI, roughly greater than 30. Diabetes also has been implicated as a risk factor. And those at risk for recurrence are those that have a stone with an increased risk of another stone of about 5% within the first year, 50% within 10 years, and 75% within 20 years. So that's pretty significant. Hopefully we can do something to intervene and reduce those rates. But if you have multiple prior stones, chances are that there may be something else that is not going to be so easily managed and is going to lead to further stone development. Subsequently, if your patient starts at a younger age developing stones, there may be a genetic component involved, okay? Male gender also is an issue, and family history also. Now, the AUA guidelines recommend a medical evaluation for anybody with a newly diagnosed kidney or urine stones. So the medical evaluation, basically what they say, a clinician should perform a screening evaluation consistent of a detailed medical and dietary history, chemistries, urinalysis, anybody with a new stone. Obtain PTH if suspect hyperpara, analyze the stone if it's available, and review imaging for stone burden. This actually can give you a little bit of assistance in terms of what may be causing the stone. And perform 1 or 2 24-hour urine studies. So medical conditions that can predispose to stone development includes primary hyperpara, Sjogren's or other autoimmune causes, osteolytic conditions such as multiple myeloma or any infiltrative disease or metastatic process that leads to bone breakdown. Malabsorption, particular diarrhea, such as seen with gastric bypass, Crohn's disease, celiac disease, and some cystic fibrosis. Ulcerative colitis is not really a big component in this, but the other ones are. Hyperoxaluria, primary hyperoxaluria, and enteric hyperoxaluria. And there are some components that are kidney related, such as phosphate wasting, Dent's disease, Bartter syndrome, cystinuria, medullary sponge kidney related to RTA, and PCKD. Any medications or herbs that predispose to stone development. Acetozolamide, because it can reduce metabolic acidosis related, and then therefore causing hypocytaturia. Topamax or Sonicidate, anti-seizure medications, but Topamax is very common actually for prophylaxis of migraines. Vitamin D excess. Now, the vitamin D excess can be bimodal. Vitamin D excess in terms of active vitamin D for the general population. Calcitriol, excess vitamin D with calcium um, can cause hypercalcemia, hypercalciuria, but also we're seeing more data that maybe those stone formers, even with regular vitamin D, even with that vitamin D and calcium that we recommend to our elderly patients to stay off osteoporosis, may be problematic in these particular patients. Vitamin C excess, anywhere from 1,000 to 4,000 milligrams, can cause problems uh, because vitamin D can be transformed to oxalate and end up with hyperoxaluria. Dietary history, what kind of foods is your patient eating? How much is he drinking? How much protein? You know, the fads, I guess the diets kind of go in waves. You know, what's old is new. Heavy protein diets are now coming back, seem to be a little bit more popular. So that can be a problem. Excess calcium, sodium, living in the South, sodium is going to be a challenge down here. High oxalate foods such as spinach, chocolate, almonds, say nuts, walnuts, almonds. I don't know why almonds particularly. Maybe just almonds are better. People like almonds better. Beets, beans, and quinoa. Quinoa. I can never say that. Quinoa. Um, I know quinoa because my wife is now making quinoa. So that's also high in oxalate. Harvard has a very nice little list of oxalate containing foods. It's not all inclusive, but it is pretty good. The Primary Hyperoxaluria Society actually had one a while back. They took it down. I think there was some problems with some verification. But there are other oxalate lists, but this one is actually pretty good. For the most part, we know kind of the foods that we want to stay away from. Interesting case was a young woman that was referred to me after she developed a kidney stone for unknown reason. She was late 20s, young professional, healthy, exercise on a regular basis, low animal protein, more vegetables, um, no family history, no history of kidney stones. All of a sudden developed a stone that required intervention. So it turned out that she was actually started juicing and started using spinach. So took on a huge oxalate load and developed a kidney stone. Once we did that, then she has been stone free.
Fred, just real quick, I had the same experience once before, and it's funny because these people say, "Oh, I'm very, very healthy. I have 6 spinach smoothies a day," But what's interesting, as you know, is kale has almost no oxalate in it. So what's ironic is someone like that doesn't want to cut their smoothies. I can't tell you how many people's lives that changed just by saying use kale instead of spinach, because spinach, as you know, has a ton. But it's interesting how people perceive it as healthy, but it's the worst for stones.
Yeah, absolutely. The only problem is I don't like kale, so so that's the other issue. But definitely something we have to watch out for. Always want to make sure you have a chemistry, calcium, uric acid, also CO level to see if there's a possible underlying metabolic acidosis component. A UA to assess the pH. You want to get the pH along with the chemistry. If you're trying to assess for RTA, you want to do it at the same time. And preferably, you want to do this in the morning. You need to correlate the two. Also, if any possible signs of infections, get a culture to see if it on any other issues going on. They also recommend PTH if you suspect hyperpara. If the serum calcium is high or high end of normal, it's worthwhile. I'll come back to vitamin D in a second. You want to analyze the stone with X-ray diffraction. So you see possibly there's a nidus. We'll touch base with that a little bit later. And then also look at the imaging. If you have nephrocalcinosis in your kidneys, there's a pretty good possibility that you have an underlying RTA also. And then also some other genetic components can lead to nephrocalcinosis. Medullary sponge kidney, and obviously PCKD. You definitely want to find out about those. They recommend doing 1 to 2 24-hour urine collection. You want to look at the total volume, pH, creatinine. You want to see if the collection is a good one. Calcium oxalate and citrate are the top 3. But then you also want to look at sodium, potassium, magnesium, and chloride. And uric acid, sulfate, phosphate, ammonium will give you an indication of the protein intake and possible acid balance of your patient. And then if you suspect cysteine, obviously you want to look at that. I really have a hard time getting my patients to do 2 consecutive 24-hour urines. It's just tough. Now, this is actually what they have on there. For creatinine, you want to look at, for females, 15 to 20 milligrams per kilogram, and then for males, 20 to 25. So if you think about 20 milligrams per kilogram per day, that 24-hour urine collection, that should give you a ballpark of whether or not that collection is a good one or not. Total volume, hopefully more than 2.5 liters. Calcium, sodium, ideally you would want it to be less than 100. That would be optimal. Oxalate, anything greater than 40 should raise a flag. Citrate, you definitely want it to be on the higher end. And then the pH will kind of help you decide which way you want to go in terms of your possible stone causes. Uric acid, ammonia, like I said, sulfate, and then cysteine. So in terms of stone types, we all know that calcium are the most common, calcium oxalate, calcium phosphate. We also have uric acid stones. We also have cysteine, struvite, and then you also have other crystallopathies, mostly due to drugs. Now these numbers will vary depending on who you read and which study or registry they're coming from. So, but overall, we're basically dealing, for the most part, in large.
So Federico, at UMC, we see a larger proportion of struvite stones.
You do? Yeah, I do not. But I do believe that, yeah. So the struvite can go anywhere from 1% to reported about 20%. So I guess it depends. So this is probably where you guys can actually tell me a little better representation.
Exactly. The total pattern.
You think somewhere around 10%?
The other couple of points before you go ahead, when you were talking about etiology, the incidence is increasing in women over the years, and in children, it's increasing.
Yes. It is definitely increasing in children. Obesity is also increasing in children. Insulin resistance is also increasing in children. The correlation is there, the causation is not. But diet also probably is implicated in children. I think maybe as we know more about which genes come into play into development of stone, that may also be elucidated a little bit further. But I think it's multifactorial. As I said, the incidence rate is increasing, as you pointed out, both in adults and in children. So stone types: acidic, uric acid, cysteine, and in the alkaline zone, you have the phosphates and struvites. Now, for calcium stone urinary risk factors, we have hypercalciuria, hypocytaturia, hyperoxaluria, and low urine volume are some of the key players. For hypercalciuria, it's actually fairly common in anywhere from 60, some say 70, 80 of the stone formers. We have this idiopathic hypercalciuria, and I'll come back to that. Primary hyperpara, also any type of vitamin D excess state, granulomatous state, vitamin D excess. We talked about osteolytic conditions, high sodium intake, simple sugar, high animal proteins. Also, not only give you a acidosis, but also results in hypercalciuria. And then there's some defects that we see in the kidney itself. Some thick ascending limb defects like Bartter syndrome, and also familial hypomagnesemia with hypercalciuria. Now, this is data from a registry on, I want to say this is Mayo. They looked at genetic and clinical characterization of a large cohort, and they found that about 103 families had biallelic components related to the stone formation, and 40 families had monoallelic components related to stone formation. So as you can see here, the blue on the biallelic, that's primary hyperoxaluria. You have also, this is vitamin D, this is sodium wasting, phosphate wasting, this is cysteine, and also in the monoallelic area, you see that this is dense disease. So they did find a good bit of patients with a genetic component associated with stone development. They broke it down a little further into primary hyperoxaluria type 1, 2, and 3. And they did find a good bit of correlation with these cystinuria. This is again phosphate wasting, dense disease, tubular acidosis, Bartter syndrome. So it was a pretty good assessment. Now, taking a closer look at this, there are some monogenic hypercalciuria genetic components, phosphate wasting, dense disease, vitamin D, breakdown disorder, and clonopathies are now being reported. For phosphate wasting, this particular study looked at, actually this is a review, but this is a review of the NAPI transporters. This is the sodium phosphate transporters in the kidney. What I'm interested in are the NAPI2, NAPI2A and NAPI2C. Those are found mostly in the kidney, and they're involved in phosphate transport. There was a study where they took animals and mutated the NAPI2C, and they found that there was an association of stone formation. So when they mutated these animals, they found that the serum phosphate actually dropped significantly in the homozygotes. Also, the active vitamin D, the 1,25-dihydroxy or calcitriol, was significantly elevated compared to the heterozygotes and the wild type. Alphos was also elevated, but the urinary calcium excretion was also elevated, and the phosphate urinary reabsorption rate was also down, meaning they were losing calcium, phosphorus, vitamin D, active vitamin D was elevated, but the PTH was only a little bit suppressed. Now, dense disease is another genetic defect where you have a X-linked recessive inheritance. So this is seen mostly in males. And it's seen with hypercalciuria, just like our furry little friends. You can have incomplete or complete Fanconi's with glucosuria, other proteins. But one of the key components is low molecular weight proteinuria. Then two, or Lau syndrome, has some ocular defects and can have cataracts and also intellectual disability with failure to thrive. The problem with dense disease is right here in this transporter in the endosomes. So we need megalin, which is typically recycled, to reabsorb a lot of the proteins that's filtered in the proximal tubule. But when you have this defect here, you can't recycle this megalin, and you end up with actually proteinuria. Some of that proteinuria is also PTH. And with PTH activation, it's thought that, at least this is the kind of general consensus, that you end up with hypercalciuria because of PTH activation that's being, or rather not being, reabsorbed. So with dense disease, you can have proteinuria, and after a while, you can start getting nephrocalcinosis and kidney stones early in life. Now, vitamin D metabolism can also be a problem. Vitamin D is activated, and you have the inactive 25-hydroxy vitamin D, which is the uracilcalciferol, and that can come from plant or animal. And then you have the activation of the 25-hydroxy in the kidney to 1,25-dihydroxy vitamin D, and that's calcitriol. So calcitriol is the active form that then increases the calcium. But if it stays on, it will continue to increase calcium. So it's eventually broken down by this enzyme here, CYP24A1, which is, well, that's the gene, but the 24-hydroxylase is actually going to break down both the 25-hydroxy or the 1,25-hydroxy. So in essence, neutralizes the active vitamin D. When you have a mutation here in this gene, then you're not able to break down or inactivate the active vitamin D. So you end up with increased vitamin D, and therefore end up with increased calcium absorption in the gut, hypercalcemia, hypercalciuria, and then can end up kidney stones. So this is a consensus slide looking at all those little defects. And what we see here with dense disease, again, is the exchanger. That's the problem. With the CYP24A1, the 24-hydroxylase is the problem. With the NAPI 2C and 2A, we have a defect in phosphate reabsorption, and we have a decrease in serum phosphate, so an increase in urinary phosphate. But what I want you to note here is that the urinary calcium is elevated. You know, we've been dealing with this idiopathic hypercalciuria for quite a while. You know, we're trying to figure out what that is. What does it mean? And it could be that it's not a single answer. It could be that we're dealing with multiple factors, okay, such as what we're seeing here. So that is another possibility. Now, we also know that we do have some patients with Randall's plaques, and the pathophys is not quite well understood, but it could be that claudin 2 deficiency or some kind of defect in the claudin 2, which is a paracellular protein, could contribute to that development. So claudin 2 is seen in the proximal tubules, and it's actually a protein that helps with paracellular transport of calcium. So calcium is mostly absorbed in the proximal tubule via paracellular pathway, and a good portion of the remaining calcium is also reabsorbed in the thick ascending loop. So claudin 16 is associated in the thick ascending loop, but these particular study showed a defect in the, or rather a mutation in the claudin 2. And with these animals, what they showed was that there was a deposit of calcium phosphate in the kidney, in the medulla. And you see this nice picture right here of all your calcium deposits here. And this was all kind of more in the papilla. And what they hypothesized was that by blocking the major reabsorption of calcium in the proximal tubule, you have a huge load of calcium now being transported distally with an increase in the reabsorption of the calcium in the thick ascending loop, leading to now a basically saturation of the medulla, and then deposition of papillary hydroxyapatite deposition. So it's a nice little model. I think it's a very good beginning to try to elucidate Randall's plaques. We kind of get the general idea that this basically does happen, but how does this happen? We're not quite sure. But with this particular mouse model, it showed some nice, interesting data. Now, with hyperoxaluria can be seen in anywhere from 10 to 50% of your stone formers. Dietary excess can definitely be a component, like I mentioned earlier in my case. I've also seen patients that are not just maybe eating a little bit of more of oxalate foods, but in one particular case, I had a patient that was actually just avoiding, did not like any type of calcium-containing product, dairy, milk, yogurt, cheese, just did not like it. Once we were able to introduce a little bit of alternative calcium-containing foods in the diet, her hyperoxaluria actually decreased. You do have primary hyperoxaluria, which is a liver problem, but also enteric hyperoxaluria. Enteric hyperoxaluria is seen more with bypass due to fat malabsorption, sequestration of the calcium, and then you have basically isolated oxalate in the gut, which then can be absorbed in the colon. You can also have a reduced colonic oxalate degrading bacteria, the Oxalobacter formigenes. So there is some data showing that a reduction in this particular bacteria can lead to increased oxalate. And like I mentioned, vitamin C excess anywhere from 1 to 4 grams can lead to hyperoxaluria. Thomas, are you shaking or are you just shaking your neck?
Touching your neck, right?
You shake your head.
You did this.
Oh, that's just the light off of my top of my head.
Fair enough. Fair enough.
The reflection.
Now, for primary hyperoxaluria, this is a rare autosomal disease, which is good. Type 1 is probably the nastier one. Type 2 and 3 are milder and less frequent. So That's a good thing. It does present in childhood with nephrocalcinosis, nephrolithiasis, and typically your 24-hour urine oxalate level is going to be higher, upwards of 80 plus. So the defect, like I said, is in the liver. With type 1, it's this enzyme here that converts glycylate into glycine. Type 2, again, it's part of the breakdown process. All in all, what you end up with is a backflow of glyoxylate, and which is then broken down to oxalate. So you end up with oxalosis, and then hyperoxaluria. Enteric hyperoxaluria, on the other hand, it's driven largely by luminal oxalate concentration, fat malabsorption, which then sequesters calcium, basically leaving displaced oxalate. Seen more with gastric bypass and anybody with small bowel resection, not large bowel resections. But there are also some transporters that have been implicated with, oxalate transporters have been implicated in also this particular entity. So the SLC26A1 can be found in the enterocytes or the proximal tubules, and this is an oxalate antiporter. The A6 is this is the luminal side, basolateral. Yes, basolateral luminal side. So in a genetic component could result with a deactivation of the A6, leading to increased, or rather decreased excretion of oxalate. So the process here in the gut is basically to take the oxalate from the blood and transport it out or dump it out. With excess oxalate, such as with bypass or something like that, the transporters actually end up reversing, and you actually end up taking in more oxalate. When you have a defect in the A6, you actually are unable to excrete the amount of oxalate that you would like, so you end up with higher levels in the blood.
Hey, Fred, can I ask you one quick question about hyperoxaluria? So assuming it's not a patient with PH, we've all read reports, or at least about, if you think about this, about with like gastric bypass patients who have enteric hyperoxaluria that actually get oxalate nephropathy, right? I've never seen it, but I know it's out there. My question for you is, in a patient that doesn't have PH, just a sort of patient that has hyperoxaluria, let's call it of unknown origin, is there a urine oxalate cutoff where you look at it, or where I should look at it and say, you should go see nephrology, you're at risk for oxalate nephropathy? Because I have a number in mind, but I don't know that it really means much, And part of it is, you hear about oxalate nephropathy, in people without pH, but I have not seen it. I do want to know what your thoughts are. Does that make sense, the question?
It does. So I gotta say, I haven't seen it either. I thought I had one, but we dialyzed them, and the oxalate level actually came down very nicely. And then there was another patient. She was a young woman with urinary oxalate of 88 or 90, something like that. And that was actually diet, interesting enough. So the number itself, I can't say what the cutoff would be. Now, in terms of actually oxalate nephropathy, I'm thinking more like in a similar process to urate nephropathy. If it goes up and then comes down, a single number is not going to be a huge thing if you have the perfect storm where you have a huge load, that may be a different story.
Well, right, but for example, the Roux-en-Y gastric bypass patients, right, that's a metabolic derangement they get for life once they have the Roux-en-Y, right?
Right.
So, you
And
know,
that process, it could be a repetitive issue.
right, and once in a while, we'll see them for stones. You guys won't have seen them. They have no kidney problems. But sometimes these patients will have a Roux-en-Y and come to us. We'll operate on them for their stone. We'll do a 24-hour urine, and they'll have an oxalate of like 80. I mean, I was going to say my cutoff was somewhere kind of 75 to 80. You know, you brought up a similar number. That just, you know, 80 is an oxalate that's hard to get to by eating, unless you're eating, you know, spinach smoothies all day. So I was just curious because, again, we read about it. I think it's probably in your guys' SASP or in-service questions too. Maybe it's not about oxalate nephropathy, but it certainly comes up in like, you know, kind of stone stuff. And so it's helpful. I'm glad you don't see it that much because there's reports of it, but I find it probably less common than the reports maybe.
Yeah, I think that the surgeons are becoming are really, really good at managing these patients. So I don't think we see a lot of the complications that we used to.
Yeah, and I think they've also gone away from Roux-en-Y or with other options, at least in bariatric surgery, more sleeve gastrectomy, less Roux-en-Y. It's obviously less of a problem.
Correct.
Could I ask a follow-up question about the enteric hyperoxaluria?
Sure.
I know the AUA guidelines talk about like a modest intake of calcium daily, with the fact that the calcium binds oxalate in the intestinal lumen. Do you have any comments on like other divalent cations like zinc or magnesium, if like supplementing with those might be beneficial in reducing oxalate absorption enterically?
Nice, I like that. Magnesium, I like it. So two things. One, you want to increase the divalent cation with food, right? So the oxalate is in the food. So you don't want to take calcium apart from your meals. You want to take it with your meals. So, you know, cheese, dairy, yogurt, milk, whatever it is, some sort of calcium containing compound. And actually, you can actually use that to reduce the urinary oxalate. And you do see, once you add the calcium, you do see, I've seen a reduction in the urinary oxalate. In terms of magnesium, haven't tried it. I'm trying to think like a high magnesium fruits. I'm thinking more
like
fruits.
Supplementing with like magnesium glycinate, pills or like zinc pills, people take just as supplements. Is there benefit from that?
That I don't know. Magnesium might be okay. I don't know what the taste would be like with your meal. Zinc sometimes can give you a little bit metallic taste, but I don't know exactly how that would play out with your meals.
I will say there's not great studies in this area, right? But for gastric bypass patients, Roux-en-Y's for me, if someone comes with hyperoxaluria and they're not on calcium supplementation, I'll either give them calcium or magnesium, right? It shouldn't matter, right? Because they're both 2+ cations, right? So there's not great studies in our literature. At least I don't know if Fred knows of any others, but a lot of the gastric, if they get a Roux-en-Y, a lot of them get calcium supplementation for this specific reason. But if they come in with a stone and then hyperoxaluria and they're not on supplementation, I'll either give them calcium or magnesium. That's what I think.
Thank you.
Yeah.
Magnesium.
And like I said,
This is Nathan withdrawal.
the key is to add it to your diet so you reduce the free oxalate.
No level 1 evidence for that one. I'm sorry.
So, but it's a very good question. And cystine stone, like I said, is a rare autosomal recessive. Normally, cystine is about 30 milligrams per day. With somebody with a defect in the transport of cystine in the proximal tubule, you can have upwards of 3,600. I've never seen that high. So basically, this is the transport, and we think that there are two proteins that transport the cystine, one actively and the other one assists. Cystine is basically a amino acid that has a sulfur at the end, and it can be reduced to cysteine by forming a disulfide bond, and this is what causes the problem in your patients. For hypocitraturia, as we know, citrate is a vital component for calcium stone formation, or rather not formation. It is a principal inhibitor, but for citrate, acid base is a key component in determining your luminal citrate level. The other thing that I want you guys to walk away from here is that you have to keep an eye on your potassium. So if you have a potassium depletion, you will have a metabolic acidosis, and that intracellularly, and that will result in hypocitraturia. So always keep an eye on the potassium when you're dealing with the citrate. And remember, your supplement is potassium citrate. Okay. For uric acid stones, they love acidic pH. About a quarter of patients with gout have uric acid stones. And then could be some inherited enzyme defects, but more so, I'm seeing more with diet. Again, the high protein intake is really becoming somewhat of an issue. But that is also something that we'll just have to work with. Some drugs can cause crystals. So the good thing, I guess, is that we're not seeing some of these. Let me take that back. I'm not seeing so many of these as much. Allopurinol, ceftriaxone, fluoroquinolones, azo, protease inhibitors, and Indinavir, we used to run across more frequently. Indinavir is not as commonly used now, so we're not seeing it that often. So that's the good thing. But basically, if you have any drug crystals, it's basically withdrawing the drug. Hydrate, hydrate, hydrate. Struvite stones, as you know, occur with urea splitting bacteria, more likely protease. And this is also associated with recurrent UTIs. So this is where I end up with a conclusion. Just to reiterate that, again, kidney stone incidence is on the rise. Stones represent a significant morbidity. Also, they're associated with hypertension. There's some reports of cardiovascular disease. Is that because of the stone, or because of the associated hypercalciuria or oxalate load? Some of the medical problems can cause or enhance stone formation. Dietary and medications can be a factor in stone formation. Obviously, high oxalate foods, any medications that can result in a metabolic acidosis. So a thorough evaluation is essential to determine a proper cause, which then will result in proper management. But more recently, genetic factors are being elucidated. So with more identification, we may have more information about how to diagnose these patients, and maybe at some point how to treat these patients. So there are some things that we can do with some of these genetic issues, like phosphate wasting, for example, and NAPI2 proteins. One of the key components to management is replacing phosphate. So by replacing the phosphate, you inhibit the PTH, and you actually are able to drop down vitamin D and drop down the calcium, which then decreases the hypercalciuria. So there are definitely some things we can do by basically playing on the physiology with these genetic issues until more is learned about them, and maybe we can develop some novel therapies. So with that, I'll say thank you for your time, and I'll take any questions.
Thanks, Fred. Thank you.
I think something that I notice, and I don't have a good answer for when this happens, I feel like it's very practice specific. Is the initiation of like hydrochlorothiazide and potassium citrate, where in your practice do you see, is it that recurrent stone former? Do you do it for most people? Are you leaning towards, really pushing and leaning on dietary modification and being stringent with that? Or do you just say that patient's probably not going to do that because they live in the South and they're going to keep eating a bunch of salt? Or do you initiate that therapy? Well, I feel like it's a little bit nuanced, but where do you see that fitting in practice?
That's a really good question. So basically, my approach is more holistic. I don't focus on any one thing. As I'm working them up, I'm trying to see what I'm going to need and trying to see where this workup so far is leading me. Excuse me. In terms of the thiazide, if we're able to bring down the calcium to below 200 with some diet modification and stuff like that, great. If not, then that's the next step. So I'm quick to either add clothalidone or indapamide to try to reduce the calcium. But I also am looking at the citrate and seeing what I can do. Do they like fruits? How much protein are they taking in? I also like lemons. Do they like their water? They come in with a little bottle of water? Perfect. Every time you go to a restaurant, ask for some extra lemons. Put it in there. 99% of my patients, I only had one person said, I cannot take lemons, any kind of lemons. Everybody else is like, yeah, I love lemons. Perfect. Go for it. Any little bit helps. So, and then the next step will be obviously prescriptions. But trying to hit it from different angles is definitely my approach. I don't rely on one thing, but it's at a staggered process, increasing the citrate, dropping down the oxalate, dropping down the calcium, and then trying to identify why they have hypercalciuria. That's the other thing. In light of all this. So yeah, you can start with clothalidone or indapamide if the calcium is high. I wouldn't wait too long on it.
I think it's by our guidelines, right? A recurrent stone former offer to work up, right? But I think some of this for me is the shared decision making. So Donish was in clinic with me this morning. I had a guy who was a recurrent stone former. I said he got sort of a few choices, right? We could do a 24-hour urine. I could give you empiric potassium citrate. We could put you on a supplement like Moonstone. You guys all know I worked on that, but that's a citrate beverage. You could take the diet, et cetera, et cetera. So you offer them, but at least for your boards, a recurrent stone necessitates a 24-hour urine. But I also believe, I don't know what Brett thinks. My take is like, I sort of tell people, if you're not interested in the drug, why am I doing a 24-hour urine, right? So, the biggest, I think, kind of fail is, okay, I'll do a 24-hour urine. Oh, okay, well, I don't want thiazide or citrate. What's the point, what I like about the 24-hour urine is that it identifies the cause, right? In theory, or sometimes it can. So I guess the point is, if someone had a citrate that was through the roof, why give them potassium citrate? So I tend to, when I do the 24-hour urines, I then focus on what the problem is. But, I think we also have to realize that there's a difference between what's the board answer, what sort of people of low means will accept, what people who don't want to take drugs won't accept, what young people won't do. Like young people don't want drugs, right? So, you can tell them till the cows come home, but at least by the books, we have to offer 24-hour urine for recurrent stone former. But I agree with Fred, it is holistic. And the thing is, if let's say they have hypercalciuria and hypocitraturia, but the hypocitraturia is 3 orders of magnitude lower than it should be, and the calcium's only slightly high, I'll attack the citrate. I tend to try and attack their worst problem first, unless they need sort of a multi-pronged approach, if that makes sense.
So another thing, Fred, what I do for patients is, oh yeah, I'm drinking a lot of water. So I said, it's not the water you drink, it's the urine that you need to produce. So I say 3 to 4 times a year, you take an empty 2-liter Coke bottle. You heard, you take an empty 2-liter Coke bottle and make sure that in 24 hours you surpass that. Whether it is summer, winter, fall, you got to make 2 liters of urine a day. And so sometimes we have a bottle that says 500 cc that makes 200 cc's, 4 of these bottles. Oh, so they didn't have a concept.
Oh, I find people I drink a ton, doc, and they have a 24-hour urine. It's got 600 cc.
Yeah.
That's ridiculous. Yeah.
Or
You know,
1200, yeah.
I'm surprised that your patients with the big prostates can actually hit the bottle, right? I mean, that's interesting.
Well, no, you get it closer to.
No, you got off the top.
Dr. Teran, I had like it's like a
But
two-part
that's
question.
an easy way to identify patients. A 2-liter Coke bottle, got it filled a couple of times a year, kind of keeps them going.
I guess my question's more for, there's, in my mind, there's two different types of stone patients. There's like your initial stone event. So I guess my question is for the patient that you've like optimized, we know that once you've had one stone event, your risk in your lifetime is exceedingly high, no matter what we do, right? You can medically optimize them as much as you want. Perhaps there's some limitations, as you were mentioning. We don't know all the different specific mutations that happen. But do you think there is a change in the microenvironment of the kidney or the exosomes that happens after you have the initial stone event? That's something that we're not capturing for why people form these initial stones? And the second question is, how stringently do you follow them to track them on a 24-hour urine, right? If they form a stone, even though if you medically optimize them as best as you can, right?
Yeah, so good question. So for me, I put into two categories. One, is it a perfect storm type of stone where all the right pieces just there at the right time, like the young woman that I talked about, they just started juicing and she just had a huge oxalate load, was exercising, so probably was a little dehydrated. Was it just the perfect storm and she ended up with stone? Once we identified the cause, that's it. I've never seen her again, Or is it the, like I said, the recurrent stone former? I've had a few of those that, excuse me, will come in. We'll go through all the process. I get the 24-hour urine because I also want them to see. All right, this is you right here. Okay, this is you. This is where you are. This is what's going on. This is what you have to work with or on. Okay, not me, you. So I tell them I'm sending you home with homework. You do it or not, that's up to you. When they get that initial stone, they come in, they're freaked out. They're like, I don't want to go through that again. The recurrent stone formers, I'm like, I've been there, done that. I can take it sometimes. So the recurrent stone formers, basically, I want them to see what's going on and what we need to work on. Is there a change? I don't know. I'm really wondering if there's an underlying problem that we're not identifying. And this is where the genetic analysis may be able to help us. So I didn't talk about it, but some of these genetic components can be seen with a little bit of a spectrum, okay? Primary hyperoxaluria has been reported pretty well, but it can also be on a spectrum. You can have a young person with recurrent stones that fits the bill, but then you can also see it in an older patient in the 5th, 6th, 7th, maybe not 7th, but 5th, 6th decade of life, and they're only identified via genetic analysis. So for me, it really would be more of a question, is there already an underlying component that we just haven't picked up? Did that answer your question?
Yeah.
I have a general question. In terms of the quality management of our veterans, I feel pretty badly when we don't have the bandwidth to like do metabolic workups for these patients and we just refer them all to nephrology. Is there like something I'm missing where there's like a order set for a 24-hour urine within CPRS, or do you manually have to click all of those to order that? Because I feel like it would be more efficient for the patient if when we refer them to nephrology, we could just order that 24-hour urine easily for them and tell them how to do it so that they could present to their first nephrology appointment already with a bunch of data and not delay their care, maybe 4 or 6 weeks?
Yeah, no, if you have to order them individually, it would take you a week to individually order those in the CPRs. Now, we actually do have a order set. It's under the kidney clinic. We have the specialty clinics,
Nice.
kidney clinic, the order menu.
Oh, that's awesome. Thank you so much.
Yeah, so it's in there.
And Fred, I totally agree with you. I'll say, I know some people are very staunch about 24-hour urines. I think the compliance with that's like an F, but it's not so hard to get one 24-hour urine. So I agree. I run it on one. It just, the patients are a lot less stressed. They're a lot less angry. It's easier. And you'll pick up any bad stuff on one 24-hour urine. I agree. I know people push, I know some of your nephrology colleagues in the guidelines push for two, but I have found one is sufficient to care for a lot of people.
Yeah, absolutely. And I always caveat that to the patient, let him know that this is a snapshot. Even if we did two, it's still a snapshot of what was going on that day, what you had, what diet you had, those few days prior to that. It is a snapshot. So, but it will give us some assessment of where we might be. And I was talking about where we might be, not where we are, where we might be, and then what we want to work towards. So they seem to understand that and get that. But I always try to let them know that this is what we're doing and this is why we're doing it. Your calcium is high or your citrate is low. This is what we have to do. And Litholink has a nice little graph with supersaturation. So I always say, look, this is where you need to be. This is where you are. Kind of like your report card. You got a D minus. We can bring it up. Come on, let's work on it. So they get that.
Thanks again, Fred. Happy holidays.
Great. Thank you. Same to you.